Good morning. My name is Giles Whalen. I'm the director of the Cancer Center here and chief of the Division of Surgical Oncology and proud colleague of Dr. Laura Lambert, who was helping us put together this third annual PMP symposium. You can't hear? I've been instructed to talk into microphones, so how about this? Does this work better? Okay. So I'm delighted to welcome you all to the third annual PMP Symposium. I want to thank you all for coming. This is going to be tough. This one work? All right. I'm certainly echoing up here. So I want to thank you all for coming to this. To have a group of people who are dedicated to the treatment of this disease and this problem all gathered in this room is really, I think, one of the reasons that we exist as a cancer center, to help advance the treatment of the disease, understand ways that we can attack it differently. And I know that this is a tremendously devoted community and devoted group of patients, devoted group of families, and a devoted community entirely. We have been very pleased, proud to be part of this effort through Dr. Lambert's work especially. This has been a year of progress for us at the University of Massachusetts Medical Center, Cancer Center. Dr. Lambert has embarked on a new set of research looking at the genetic expression of a variety of different types of appendiceal cancer to see if we can figure out which cancers behave worse, which behave better, which are more responsive to chemotherapy. We've just received funding to undertake a phase 1 clinical trial employing new varieties of chemotherapy and new strategies to manage this problem as we go forward. Today we have a distinguished group of experts and visiting professors, Dr. Armando Sardi, who I know is known to many of you from Mercy Hospital in Baltimore, and Dr. Masraji from the Mass General and Harvard Medical School to talk to you about the confusing nature of appendiceal pathology. And I'm sure that Dr. Lambert will discuss some of her recent work as well. So this is as I say, a program that we feel represents in many ways what we should be doing as a cancer center. We're delighted to be doing it and supporting it, and we're grateful for all your efforts. In fact, one amongst you has brought in an endowed chair, and the professor of that endowed chair, who's developed an amazing mouse model to help advance research in appendiceal cancer, will be talking to you later today, Dr. Dale Greiner. So with that, I will turn it over to the real substance of the program and introduce Dr. Lambert.
Good morning, everybody. Thank you so much for coming. I'm actually going to first turn the time over to Mr. Jim Carroll, who is one of the vice presidents of the PMP Research Foundation, who is underwriting our symposium today, and with his colleagues who are just making great strides to raise money for research to cure this problem. Jim.
I'm going to try this mic because last year I figured out I couldn't hold the mic and turn pages at the same time, so please bear with me. The PMP Research Foundation is proud for the third year to collaborate with UMass Medical Center through sponsorship and participation in today's symposium. Let me begin by thanking Dr. Lambert, Dora Halleck, and the Planning Committee for putting together an outstanding program today. I'm excited to take a few minutes and share our foundation story with you. For most of our board members and many supporters within the patient community, our stories are very similar. The story begins with a diagnosis of PMP, appendiceal cancer, or oftentimes a misdiagnosis of PMP, followed by a struggle to understand the disease and seek out potential treatment options. Oftentimes this occurs in an environment where the doctors being consulted for treatment and diagnosis have never seen PMP before and have limited or no knowledge. For patients, it can be a roller coaster of emotions with decisions being made having life or death consequences. For Judy Culbertson and I, that journey began in 2004 when her beloved husband, Dutch Culbertson, was diagnosed with PMP. He was my best friend. Dutch lost his courageous battle to PMP in 2006. Following Dutch's passing, Judy set out to make a difference for Dutch. And we went about starting to do cancer walks and raising funds for the disease, only to find out that there was no real central charity doing any type of research that we could donate the funds to. And fortunately back then, we discovered the newly formed PMP Research Foundation. The PMP Research Foundation was formed in 2008. The foundation was created by Lisa Luciano, a courageous PMP patient and mother of 8 children, who recognized the need to support the medical specialists through funding research. Lisa created the foundation along with her co-founders, a group of individuals affected by PMP, including Jerry Lewandowski, our current president, Mike Dvorsky, Dan Luciano, and Kathy Hoover. Susan Ortega, Judy, and I subsequently joined the foundation in the first year. Sadly, Lisa Luciano and Mike Dvorsky in 2012 passed away. They were outstanding people with outstanding vision who contributed to, from the very beginning, setting our foundation in motion in an attempt to try and seek out a cure for PMP. Our mission, we're dedicated to funding research to find a cure for PMP. Our initial goals were to raise $1 million to fund important research within 3 to 5 years and to play a leading role in the dissemination of accurate information regarding PMP, both to the patient and medical communities, to drive education. This is our professional advisory board, and although we're a young foundation, we have built an organization that will hopefully improve the quality of life for patients and hopefully someday bring a cure to PMP. We believe that working with this professional advisory board of outstanding specialists, including Dr. Lambert and Dr. Sardi, will help us achieve those goals. Our commitment to PMP education is shaping up in the form of symposiums very similar to today's symposium, and we also have begun funding small scholarships and grants to bring people in the medical community to symposiums like today. I want to just touch on a couple of things that we do to raise funds. This is the Make a Difference for Dutch walk and 5K that we do in Philadelphia. We have the Summer Scurry that Lisa and Dan Luciano began out in Ohio. We have Team Doug and Lindsay have done the Hartford Marathon, friends of theirs, and they also run a pub crawl, which is our most interesting fundraiser. We should actually try to do a national pub crawl. I think we would raise some money pretty quickly. DC Rocks PMP, this is in the Massachusetts area as well, and Derek Corner runs a night of rock and roll to raise funds for PMP. And this was a walk that just began last year in Wilmington, Delaware, by the Serbu family. We do a lot of marathon runners that sign up and want to do small events, and we've had a couple of those recently. Mike Dvorsky's son and daughter ran an event like that, and the good news at this point is that 5-year goal of reaching $1 million, we're within $35,000. So we're at $964,000 as of last week raised. So what do we do with the funds? We basically have a grant program, and our grant program is administered by the National Organization of Rare Disorders. They do the RFP development and scoring. It takes place where it's openly advertised and people submit for it. And as of this year, we've granted 11 awards for $550,000. 2 or 3 grants, we make the decision at this time every year, are pending for 2013, and they're about to be awarded. This gives you an idea, and I certainly can't go through the names and the organizations, time wouldn't permit, but it gives you an idea of the broad range of people that are working on this disease that have applied for and been awarded those grants. And you can see that it's not only in the U.S., but we've touched places overseas, and you can see that quite a few people are now trying to find a solution and find a cure. In 2012, we reached Tokyo, Japan, and Dr. Levine from Wake Forest were the most recent ones last year. To our specialists, Dr. Lambert, Dr. Sardi, and all of today's presenters, we thank you for your leadership and support and ask for your ongoing support and participation. To the doctors, nurses, and students in today's audience, we are appreciative of your attendance and firmly believe that you'll be able to apply the education you receive today and affect the outcome of patients in the future in a positive way. To the patients in the audience, we want you to know that you're not alone. Know that we're here to support you and invite you and your family members to join us and support us. Things are changing in a positive way. Know that progress is being made, and there continues to be many, many success stories in people that are beating this disease. Stay strong and never give up. Thank you very much.
So what I thought I'd like to do to start is to give an update on what's new in appendiceal cancer. But before I can even begin to start that, I want to say that this day, this symposium is your symposium. It is for the people who have dealt with or are dealing with appendiceal cancer or PMP, their families, their providers. This is really your day, and I hope that you will have a chance to meet other people who are in either the same situation or similar situations or have questions like you do and be able to ask those questions of our speakers. We have a wonderful agenda today. We have some very knowledgeable people who are here. Please feel free to ask any questions that you have. And I also want to start by just acknowledging the people who have made this possible today. Obviously, Jim Carroll and the PMP Research Foundation for helping us fund this event. Ms. Dora Halleck, without whose help I certainly would not have been able to pull this off. Pam Devaney, who helped us with the marketing. Dr. Giles Whalen, who you heard from, who is also the head of the Division of Surgical Oncology and my boss and a wonderful mentor. Ms. Sheila Burke, who's the Administrative Assistant for Surgical Oncology, and if any of you have seen me in clinic or had an operation here, you've met with Sheila or spoken to Sheila, and you know what a wonderful person she is. Dr. Mary Sullivan, who's our nurse practitioner and the glue of our Division of Surgical Oncology, and who has helped many people get through this disease and the surgery and all the things that come with it. Dr. Bradley Switzer, Dr. Vina Bathini are the two primary medical oncologists that we work very closely with, who have met a lot of you and have a real focus and interest in appendiceal cancer and finding the best treatments for people that are dealing with. Dr. Otto Walter, who's our pathologist, who also has a dedicated interest in this disease and is really trying to help us sort through the issues of pathology, which we're going to hear about more later from Dr. Mistragi. We are really starting to develop some new research programs, and we are actually starting to get a critical mass of people on the research side. Dr. Lloyd Hutchins, Dr. Edith Kozar, Tom Thomas, I can't pronounce his last name, sorry, he's and Dr. Dale Greiner, who's will also be speaking about the new mouse model and the the endowed chair that he received for appendiceal cancer research, and obviously Gabriella Graham, who all of you are probably familiar with through PMP Pals and the support that she offers. I also need to thank the nurses, the oncology nurses on the 7th floor who take such wonderful care of our patients after the surgery that they have. Without them, this program would not work. Our perfusionists that help us with doing the heated chemotherapy, and we actually have the device that we use to do the HIPEC. If anybody's interested in taking a look at it and seeing how it works, we'll be happy to show you. And obviously the staff in the operating room, without whom none of this would be possible. And I'm sure there are other people that I have forgotten to mention, but I just want to thank everybody who's helped with the symposium today. So what is new in appendiceal cancer, PMP, in 2013? And I didn't make this a question on purpose because there's actually a lot that's new. If you look through the literature, I don't know, just a couple of years ago, you would see some case reports. Oh, we had a person that had PMP, and this is what we did. This is how they did for a little while. Or a program, we're doing HIPEC, the heated intraperitoneal chemotherapy, and we've done, 25, and we didn't have any, everybody did well, and this was our complication rate. And that's kind of all you would see. You wouldn't really see anything about the disease, what's going on with appendiceal cancer, what causes it, what are the specifics about the biology behind it, how can we treat it better. And that's a real change. So if you look through the literature in 2013, what you're going to see is we're starting to get some answers to what I call the frequently asked questions, that when somebody gets this diagnosis and they come to the clinic, there are questions that come up. And one of them is that appendiceal cancer is really rare, isn't it? Well, we recently published a paper. We looked at our incidence of appendiceal cancer just here at UMass. We went back 5 years. We looked at all the appendectomies that we did, and we found that 3.7% of all the appendixes that we took out had a tumor involved in them. Not necessarily a primary cancer of the appendix, but they all had a tumor involved in them. And what was even more remarkable was that if the person came in with what we call a ruptured appendicitis, where the appendix had burst, and we then took out their appendix, 30% of those people had a tumor, an appendiceal cancer, involved with their appendix. Now, the estimated incidence of appendix cancer is 1 in 10,000. That's 0.01%. And we're seeing 3.7%. I know many people have said to me, it's rare. It is rare, no question, it's rare. But I don't think it's as rare as we think it is. I think we're really starting to recognize it for what it is. People are not being as misdiagnosed as they were before, and we're starting to really see that the incidence is much higher than we thought it was. And our paper is not the only paper to show this level of incidence. There was actually another paper published in 2012 that showed almost identical numbers from Arizona. So a very different place than Massachusetts, which means this is not just a fluke of Worcester and something that's happening here in the environment. This is real, that the incidence of this disease is much higher than we ever thought it was. The next frequently asked question, and I was just talking to someone in the audience about this, is the question, is this cancer? I mean, this is one of the, so in addition to this being rare, it has one of the most confusing pathologies to have to deal with. You get this diagnosis, you're told you have a tumor, it's not really cancer, but it has problems that can go on to ultimately threaten your life. So, how do we classify this? Well, as a matter of fact, even the pathologists who deal with this on a regular basis have a hard time figuring out how to classify this so we know what to do. And as a matter of fact, just recently in May, there was a consensus meeting in Basingstoke, England, where the world's pathologists, the experts in this around the world who are interested in this problem, gathered to try to answer some what you would think are very basic questions. Do you believe PMP, that's the pseudomyxoma or the ascites that comes with this, should be used for the macroscopic appearance of mucinous ascites, not as a histologic diagnosis? And they are talking about the very basic big categories. How do we describe this? Are we calling this, is this the pathology, or is this just a description of what this looks like when we see it? The next two, should it be considered cancer? how different levels and ways of describing this. I'm not going to dwell on this very much because Dr. Mastraggi is going to touch on this in his talk, and he's going to be able to go over this in much more detail. But as confusing as it is when you're the person that's got the diagnosis, it's reflected. It's confusing for a reason because we haven't sorted it out yet. Even the pathologists haven't sorted it out yet. But it's coming. This was a recent publication by Dr. Logie out in Nebraska, where anybody that goes online and starts looking at this disease, you see something called the signet ring cell. Those of you who have looked into this, you know that there's a spectrum of this disease. At one end of the spectrum is a more slow-growing, less aggressive type of tumor. At the other end, we talk about the signet ring cells. Dr. Logie has looked at this disease and found that if there's any signet ring cells anywhere in the biopsy or the specimen that's been removed, that it really impacts survival. So this is a very important. We're starting to get clues about the pathology that will need to be followed up on. The next question I get asked very often is, can a person have more than one HIPEC surgery? And the answer to that is actually yes. Oftentimes we say, I tell people yes. Not very many people would probably want to go through it, but if it was necessary, people do go through it. And actually, Dr. Sardi has recently published on the feasibility, the safety, the ability to do this, and the fact that it actually helps in highly selected people to do a second HIPEC if necessary. And he's not alone. The group from New Zealand, in combination with Dr. Verwal in the Netherlands, has also shown that it is possible to do repeat HIPECs, that it's safe, it's feasible, and it can be helpful in selected patients. A couple more frequently asked questions are, how successful is the HIPEC? Obviously, anybody that's facing the surgery and thinking about having the heated intraperitoneal chemotherapy wants to know is, how does it work? Is it really going to help? And the question that we are always asking the surgical oncologists and the medical oncologists is, how can we pick people that are going to benefit the most? We obviously don't want to put people through an operation, especially of that magnitude, if it's not going to be helpful. So are there things that we can look at that can help us pick the people who are going to benefit from this the most? And what we're starting to see in the literature finally is people are looking at what we call tumor markers. So tumor markers are proteins that can be measured in the person's blood, and they come from cancer cells, and they are a reflection, we think, that there are the amount of cancer or the presence of cancer in a person. And Dr. Duraco and his group from the Cancer Center in Milan, Italy, has looked at using tumor markers to actually predict which patients which people will benefit from the surgery, the cytoreduction and the heated intraperitoneal chemotherapy. And what they found is that there are above certain, that the tumor markers, the levels of the tumor markers actually do correlate with both the ability to get a complete tumor removal, which is so important, as well as the person's survival. So these are tools that can help us pick people to have the surgery for whom they're going to benefit. And the same thing, similar finding, again, from the group down in New Zealand, looking at the tumor marker CA19-9. And they have found that depending on the level of the CA19-9, if it's less than 100, people do very well with a greater than 90% 5-year survival. If that number goes very high, 1,000, normal is about 37 for those of you who are wondering. It can impact overall survival. And again, this is important when you're trying to pick which people should undergo the surgery and the heated chemotherapy. And similarly, another study, even out of Japan, looking at one more tumor marker called the CEA, has also shown that the CEA level may help us to identify and help pick treatment approaches. What causes appendiceal cancer? But this one, everybody, I wish we had the answer to this question, right? Because if we knew what caused it, it would be so easy we could just take out a person's appendix who was at risk for it. It would be that simple. Unfortunately, we don't know. A lot of people always ask, is it inherited? We have not, nobody that I know of has seen any families that it runs in families, so unfortunately we really can't use that to identify if people are at risk. But what Dr. down in Baltimore, the group that works with Dr. Sardi, have doing a very interesting research looking at the bacteria in the appendix. So the appendix, we used to think that the appendix didn't play any role, that it was what we call a vestigial organ. It doesn't play any role except to get people into trouble, right? It causes appendicitis and it causes cancer, and that's it. But actually, we do think now that it does play a role, that the appendix is actually lined with what we call a biofilm, and that there are bacteria that grow in this biofilm, and it's like a reservoir for bacteria to replace the normal bacteria in our guts. So if we get a virus and it kind of wipes out the bacteria that normally live in your gut, it will be replaced through the appendix. And what Dr. Gilbraith and Dr. Sardi have shown is that there are actually multiple different types of bacteria present in pseudomyxoma. In the appendix, when they've taken out the tumor and they've looked at it, they've actually found different types of bacteria that are in there, not inside the appendix necessarily, but outside the appendix, inside the tumor. And they've shown that these types of bacteria are similar across different patients. And they've gone on to do a pilot study where they've treated patients with antibiotics before and after surgery and found that there may be a survival benefit to treating people with antibiotics. Now, wouldn't that be a wonderful, wonderful thing if we could treat people with medications that we already have that don't cause you to lose your hair, don't make you have nausea, don't wipe you out, and be able to have an impact on people's outcomes. And they've actually gone on to do another clinical trial where they treated people with antibiotics before surgery, and what they were able to find was that they could actually see a decrease in the number of bacteria in the tumor specimens when they took them out. I don't want to steal Dr. Sardi's thunder if he's going to talk about this at all, but this is really important, and it's a very exciting thing that's coming up this year. And he's also shown that there is a protein that comes up in the cell membrane that acts like a little anchor that helps cells to not be able to migrate. That's called beta-catenin. So he's actually seeing on the very cellular level changes that occur when people get treated with antibiotics, changes that are helpful to prevent cancer from spreading. The group down at MD Anderson took a look at something called microsatellite instability. This is another mechanism by which tumor cells become cancerous. This is very common in colon cancer. It's actually not very common in appendix cancer, and it's rare to get a paper published with a negative result, if you will. So I'm thrilled that they did, because this is important. This tells us that appendix cancer is not colon cancer. It's different. It has a different biology. Right now, we are lucky that the chemotherapies that we use for colon cancer work against cancer of the appendix, but this is a different disease, and we need to think about it differently. And this, you know, with the research that people are doing now, we're starting to get this information. Dr. Sardi's group also looked at something called VEGFR2. This is a receptor that's important for cancer cells when they're trying to develop their own blood supply. And it gives us a target. We actually have drugs that are targeted against this receptor that we can use to treat cancer. And what he has found is that people that have high levels of this receptor, it is a bad prognostic factor. People that have low levels, their tumors do better. But this is giving us information about these tumor cells and ways that we can attack them better. And then this is a study that came out of a group in Japan where they looked at the mutations in the DNA of appendix cancers, of low-grade appendix tumors. And what they found was that there was this gene that is mutated called GNAS. And this is the first report of this in tumors of the appendix. And it is associated with another gene mutation called KRAS, which was very high. The KRAS was 94%. The GNAS was 50%. And this GNAS is an interesting gene because it appears to play a role in the production of mucin by these cells. So when these scientists took this GNAS gene and they stuck it into other types of colon cancer cells that don't normally produce mucin, or the stuff that makes the PMP, they found that the colon cancer cells started making the mucin. And so this also may be a target, because the big problem with appendix cancers oftentimes is the mucin that gets built up, the pseudomyxoma. So this may be another place to start looking to target. And we actually did a similar project. We were not specifically looking for any gene mutations, but we recently did a study looking at a number of different tumors using something called next-generation sequencing that looks at 50 different possible mutations in cancer cells. And what we found was that 68% of the tumors that we looked at had this GNAS mutation. So these results we're going to be putting together and getting published, and this will be the second finding of this GNAS mutation. So we think that we're onto something here as a potential target for future treatment. So then the next question is always, are there any new treatments? What's coming down the road? You know, we've had the surgery and the HIPEC now for a long time. Well, right now, if you look through, for clinical trials, there's currently 4 actively recruiting clinical trials in the United States. The MD Anderson Cancer Center has a trial looking at intravenous chemotherapy in low-grade appendiceal cancers, not something that we traditionally think of as being responsive to intravenous chemotherapy, but potentially another arrow in our quiver. The Memorial Sloan Kettering Cancer Center down in New York is looking at a combination of the tumor debulking surgery or the cytoreductive surgery and randomizing people to either get intraperitoneal chemotherapy as an outpatient or the HIPEC, and to see if there's a difference between those two, you know, with the hyperthermia and without. There is a phase 1 study, which means that the study is looking at the toxicity and the safety of a treatment. You're looking at the use of intraperitoneal oxaliplatin in combination with intravenous chemotherapy, and that's in St. Louis for people with appendiceal cancer. That's after surgery. And then there's a multi-institutional study by Wake Forest, MD Anderson, and the University of Pittsburgh looking at comparing oxaliplatin and mitomycin for HIPEC. And what's new here at UMass? Well, we, as Dr. Whalen mentioned, we recently received some funding to start a phase 1 clinical trial that we're in the process of getting up and running, where we're going to look at the role of intraperitoneal oxaliplatin in combination with standard of care, state-of-the-line systemic chemotherapy for appendiceal cancer that cannot be resected, to see if they can get a benefit of giving the chemotherapy directly in the peritoneal cavity as well as intravenous, and see if we can have an impact for people who are not candidates for the cytoreduction and the HIPEC. We're also interested in prevention, and we're putting together a proposal to do what we call brush cytology of the appendix. When a person has a screening colonoscopy, to put a little brush in the appendix, brush the cells and see if there's any sign of an early tumor developing, and if that was the case, take out the person's appendix at that time. You're going to hear more about the research that we're doing to try to develop personalized medicine for appendix cancer by Dr. Greiner, and Dr. Mary Sullivan later is going to talk to you about our early postoperative abdominal sparing exercise program for people who are recovering from HIPEC surgery. So the future is bright. I know that was a lot of information. It wasn't designed to really you know, give you next steps in treatment or anything like that. It was designed just to let you know that the landscape is changing. We're not just talking about cytoreduction and heated intraperitoneal chemotherapy anymore. Finally, people are starting to look at this like a real cancer. We're starting to look at the molecular, what's happening at the molecular level, what can we target to treat this, and what can we do to cure this, and how, and just the scope of what people are interested in with this disease is expanding. So I just wanted to leave you with that you know, the future is bright, things are moving forward, there's lots of people who are engaged in this, and I'm just so glad you're all here today. So thank you very much. So next, I would just like to introduce our keynote speaker for today. Thank you. Dr. Armando Sardi probably doesn't need much of an introduction to many people in this audience. Dr. Sardi is the Chief of Surgical Oncology down at the Mercy Medical Center in Baltimore. He has been doing cytoreductive surgery and heated intraperitoneal chemotherapy for probably 30 years now, I think he said in the grand rounds this morning. He is a world's expert on the management of appendiceal cancer. He's got many, many publications, as you saw in my presentation. He's given many presentations. I had the privilege to see him operate during a symposium that he held down in Baltimore in June, and I can tell you from one surgeon to another, he is incredibly talented, consummate surgeon, and just a wonderful physician. It's been great to work with him. And so I introduced Dr. Sardi.
Thank you, Dr. Lambert, for such a nice introduction. Really, this happens only because of the help of a lot of people. This is not something that is only one person doing it, but a group of people that make things happen. Technology, no? Anyway, thank you. First, I want to thank all of you for being here today. I want to thank Dr. Laura Lambert for inviting me to be here. This is a passion of my life, which I enjoy doing, helping people with these diseases. And also the PMP Foundations and all the supporters for allowing this to happen. As this expands all over the world, and more often, and more patients are going to benefit from this. The majority of patients that should be treated are really not being treated yet, believe it or not. And some of you have had the opportunity through mainly the internet really get connected, which is kind of crazy because even physicians still have very negative attitude. And I can tell you that there are very few treatments in cancer today for advanced cancer that have even a piece of the results that we see with peritoneal carcinomatosis, which is rather impressive. And as a physician, I cannot understand why. We actually are a small hospital in the middle of Baltimore between two giants, University of Maryland and Hopkins. So when we apply for funding, we usually get denied because we are not a university. But thanks to the collaboration of patients, we actually have been able to do a very aggressive research and have been able to expand a lot in the treatment of patients with peritoneal carcinomatosis. What I'm going to try to do today, and I apologize, there will be some slides that are not that nice to see probably. Try to get rid of as many as I could, but I think it's important for you to see what, and try to explain from the clinical point of view, what is PMP and what is appendiceal cancer, and how do we make the decision to get you to have a good quality of life and hopefully live many, many years. The appendix, as Dr. Lambert said, really is this organ which doesn't count for too much. The average size about 6 centimeters, about 2 inches, but it could be as long as 6, 7 inches, almost 20 centimeters. Initially, we thought it was something that had no role in anything. Actually, we have learned a lot more. As Dr. Lambert said, there's actually a lot of roles that the appendix play today in our benefit. It has appeared mainly in immunological aspects in early life that actually may expand to the early adulthood. House for good bacteria, as Dr. Lambert mentioned, help us to do all the things and improve our gut flora when it's damaged by any disease or other processes. Also, we use it occasionally for reconstruct ostomy that can be continent, ureostomy, or reconstruct the ureter, in addition to have other important roles as mentioned above. So it's really not something that we thought it was there that belonged to someone else and had no purpose. Now this is where you want to find your tumor, if you have one. And unfortunately, doesn't happen that often. But here, this is appendix. This is the normal size of the appendix. And this is what we call a cystadenoma. This is a distended appendix with mucin in it. If you get this, and sometimes we diagnose this, like in this lady, by had a CAT scan for another reason, we did an appendectomy, she's cured. No follow-up, no disease, no HIPEC. So all that is actually very important. And this is the other thing. This is a few months later, and no one knows because this is a process that probably takes several years. Here, this is the colon. This is a normal appendix. And then you have this dilated appendix. Now the mucin is coming through. I don't know if we can turn the lights down a little bit, maybe but this mucin, which is a jelly, is really a jelly belly that's expressed to all the abdomen, and that's what happens. Now the appendix can rupture in two ways. One, it can rupture and present like appendicitis. Here, there's a tumor, but the tumor actually burst and patient presented with a pain with appendicitis. Or could be this slow process that kind of starts seeping out, just through the wall, and then when the patient come to us, then they look like they are pregnant. They have this mucin everywhere, but it's a slow process that goes throughout many, many years or many months. This is actually probably one of the ugliest pictures that I have, but this is a lady from Monday, actually, that had this jelly. This is what is called pseudomyxoma peritonei. 1.5 liters of this jelly that really you just pour out of the abdomen and clean it up, and that's what you see. That's why it's called pseudomyxoma. The PMP name comes from, which is really not a clinical condition. This could be a very low-grade tumor, the deep palm, or the higher-grade tumor, which we'll talk about in a few minutes. Sometimes you see this. This is actually an omentum. The omentum is an apron of fat that we have on top of the bowel. And this is actually, it's called the omental cake. For some of you see it, it just becomes like a hard rock area with tumor. And here you can see the small bowel. Fortunately, the light doesn't let see, but you can see these loops of this tumor really attached to it. This is actually a benign condition from the point of view that started as a cystadenoma, and now it's malignant, and that's where it comes. Now we don't talk benign or malignant, and that's where the pathology gets confused, is that this is what we call, when it's in the appendix, when it's ruptured, it's a low-grade neoplasm with a non-malignant potential. Not every appendix like this that perforates leads to this pseudomyxoma, but when it does, has the potential to actually kill people. This patient could not be completely reduce or remove all the tumor because it was involving pretty much every segment of the bowel and it could not be cleared appropriately. And sometimes you see something like this. Pretty impressive. men, women that come in with huge bellies associated with this condition. Now, then you have the higher grade, which you see the PMCA that's called insignia ring cell, which mentions cells that are more aggressive. Here the appendix is actually hard and indurated. There is fluid, but this fluid is not mucin. It's actually clear fluid, which is actually the one that is associated with poor prognosis. And most importantly, this is actually small bowel. And this is something that a CAT scan cannot show you. And these are these hard nodules that this is where the vessels come in through the bowel. And you have these hard nodules that are penetrating to the bowel at all levels that are very difficult to remove. And when it affects the whole small bowel, it's not good. So this is an aggressive tumor, again, presenting in a different way. And you look at this CAT scan, and the CAT scan looks completely normal, a very small amount. So this will be explained later by Dr. Misrachi. But this is initially divided into two categories. Actually, there was a fellow, Dr. Ronette, that being a fellow at Hopkins, got 66 patients from Dr. Sugarbaker and decided to categorize, and without she knowing, became actually famous for that reason, and she was talking to us a few months ago. And actually, it's not even her interest anymore, but she's known for that reason. And really, it's a very kind of very generalized category that doesn't really tell us the whole history of what's going on. What is really happening from here to have a low-grade tumor? The palm comes from disseminated peritoneal adenomucinosis, or the mucin, to a high-grade tumor, which is PMCA, which is adenocarcinoma, and goes from very bland epithelium, which is epithelium, when you look at it, looks normal. That appendix that you saw that hasn't not perforated, when you look at it, there is no malignant cells that look like malignant, don't have any characteristics, has a lot of mucin. While in the other side, you have these aggressive cells that are actually penetrating, more aggressive. But in between, we had a wide range of behavior. And now we have almost 260 appendix cancer that we have followed up to 15 years. So we are now categorizing histopathologically, trying to put all the genes that Dr. Lambert mentioned about and see where, because I think we have probably 5 or 6 categories in between these two, in order to better describe the chance of a person to have a recurrence. And now, because we have the follow-up for so many people for so long period of time, we be able to correlate what was found to survival and try to categorize and do probably better staging. Now, how do we make the medical decision or the clinical decision to do a big operation if someone comes with a perforated appendix? Again, if you have a cystadenoma, which is the unruptured appendix, no additional surgery, no follow-up. Usually we'll do a CAT scan a year to make sure that everything is okay. Then you have the mucinous tumor of low risk. We don't do, and this is a patient who actually has cells. It's a little perforation, but just using no membranes outside of the appendix. In that case, we will just follow up this patient because this patient can recur. If the category of the group 3 is the group that now you have a ruptured appendix, you have mucin, but you have these benign membranes outside of the appendix, that is a bad prognostic factor. That patient needs a HIPEC at that time because it's the time when you're going to find very little disease and they're going to do better. But that patient is already a high risk of having recurrence. Of course, if you have a carcinoma, you need to have the colon removed on the right colon because of the lymph nodes, which you don't need to do in these other categories. If you have a true low-grade mucinous neoplasm, you don't need to have your right colon removed. It's because it doesn't go to the lymph nodes, and that's a well-known fact. So really the pathologist looks, and I won't want to spend too much time on this, but look at several characteristics that help us as physicians to make the decision on how aggressive we should be. You know, not because we have evolved in surgery from being very aggressive, and I had lived long enough, fortunately, to look at the very aggressive surgeries to the lesser aggressive, and really not that big surgeries don't work. They work. It just has to be applied to the right people at the right time so we don't hurt people, because we can also hurt people if we do the wrong treatment. Now, this is where you want to find your appendiceal tumor. You know, this is an appendix, and here you have a mucin, inside the appendix. It was found by an incidental finding when the CAT scan was being done for something else. I went in the wrong direction here. Then you have, sometimes you present this, which is now these big bellies with a lot of tumor, displacing the bowel. In many instances, we actually see more advanced disease, spleen involved. This is the stomach tumor on both sides of the stomach, around the liver, on the periphery of the liver. So rather more extensive disease. Unfortunately, many patients get to us with this amount of disease. Sometimes, and actually I took out the actual picture of the patient because the tumor actually was growing out of the abdomen, just coming out. He had had an operation, the wrong operation, when the tumor just was out of control. So what are the options for treatment? I mean, how do we deal with this? Really, the standard of care today for patients with appendiceal cancer is cytoreductive surgery and HIPEC. And actually now, in fact, physicians are being sued by not referring patients to the appropriate care early enough when this diagnosis is made, because there is no other procedure or any other treatment that can give you equal results wherever you look at it. Now, what is cytoreductive surgery? You hear all this, okay. It really means removal of all the tumor, visible tumor if you can. Okay, or leave tumor behind that is less than 2 millimeters. I will explain that. Why is that? But sometimes, depending on what it is, it requires the removal of many organs. And again, that's where we have to be very careful of what we do, because it will impact the quality of life of the patient. Okay? But the most important prognostic factor is not the chemotherapy, it's not the heat, it's not the type of machine, but it's how much tumor you leave behind. This is true not only for appendix cancer, but all the other peritoneal malignancies. Just to give you an idea, we just started a prospective randomized study for ovarian cancer, which I think is the ideal treatment for this, but it has to be proven. We do it for recurrent. But in the United States today, 80% of women present with advanced ovarian cancer. And only, including the major institutions, only 15 to 25% of women get the right diagnosis, the right surgery in the United States in 2013, which is very worrisome. Why? Because there's a lot of disease in the upper abdomen, and the gynecologists, oncologists don't deal with that on a regular basis. And that's what the problem is. So that's a big improvement that needs to be made, but there are now 4 studies going in Europe, and we're trying to do that. Now, there's a patient which some of you know. He actually told me I can tell you about it. It's actually Chris Pekorski, that with PMP Pulse, and he's 7 years out now. But when I went to surgery, he had written this out, and he knew by the internet that I had to do a good job with him. Anyway, what we're trying to do is complete cytoreduction. When you mention about CC score, this is what's called complete cytoreduction score. It means how much tumor we leave behind. For us as surgical oncologists, this is good cytoreduction. In other words, we are going to leave behind is a not visible disease of tumor less than 2 millimeters, which is really pretty small. Why? Because that's when the chemotherapy can do a good job. The level of penetration of the intraperitoneal chemotherapy is only about 3 to 4 millimeters at best. So if a surgeon, I want to go home earlier, then I'm not going to help the patient. Okay, and that's where the problem begins. You want to come here from this, a lot of jelly all over the abdomen, and this is delivered with this is cauterized. We use the electrocautery, very cheap instrument. We are able to really clean everything. This is the diaphragms, and everything, every organ has been cleaned up. You can see a very nice cytoreduction. Now this is and then follow at the same time with high concentration of chemotherapy. Why? You can put a lot of chemotherapy in the abdomen. At that time, you are going to wash, and clearly, after all this tumor, there has to be some live cells around. The group at Memorial for years were doing the cytoreductive surgery and HIPEC, but without removing all the tumor, it doesn't work. Even though people can live longer, everybody ends up dying by 15 years or so, 10 years, even with low-grade tumors. So high concentration of heated chemotherapy. Now, heat, this machine, actually multiple machines, they're all the same thing. All it does is a simple thing that has a pump, a rolling pump that rolls chemotherapy inside, comes out, is heated, and the idea is to keep the inside temperature coming in at least 43 degrees, coming out as close to 42 as you can. When you go higher than that, then you start having some toxicity to the normal tissues. Now, heat alone kills cancer cells, but most importantly, enhances the effect of some chemotherapy agents. And that is why, and tumors in general are more sensitive to chaotic environments, like low oxygenation, heat, all that, the cancer cells are more likely to die than the normal cells when that is put in. Again, I get the credit for this, but it's a big group. Without all these people helping us, from the floor to the ICU to the intensivists, everyone is important to make this happen. It's people who actually I have been very honored to work with them because they don't look like they are working. They love what they do. When they ask me, why do you stay 12 hours in the operating room, I'm enjoying what I'm doing because the outcome of what we see. And really, as a physician, you have to be committed because it's very easy to give up. There's so much tumor, and we train fellows on this, and they say, wow, Dr. Sardi, this is too much. And you can start working, and you have to be careful when you do the operation to work in different areas without cutting before you know that you can put things back together. Because that's the problem. So much tumor that you have to be very careful. Or, it's not just like doing a colon resection or do this and then go to the, you have to do a little bit here. Okay, this is doable, that's good. Okay, it's doable. And then you work like that around until you get everything done. And I used Dr. Winston Churchill's 5 famous words: never, never, never give up. And it's interesting because one time, after 10 hours, you say, okay, what do I do now? And then the fellow told me, Dr. Sardi, remember, never, never, never give up. So, okay. So the patient, I used to admit the patients the day of surgery. I stopped doing that about 15 years ago. Why? Because people come from out of town, they get dehydrated, they are worried. Most of patients have been told that there is no hope, that it's crazy, that you are going to die. Your medical oncologist had fought with you because you decided to get a second opinion. I mean, all kinds of stories that probably Larry Todd and other people can tell you later, which are really sad to some extent. So we learned that if we admit the patient before, we have a group of a team that can really sit down with the patient and explain everything. We mark everybody for possible colostomy. Only 25% will get a colostomy. We do everything possible not to give one. And I don't do protected colostomies or ileostomies. Usually I put everybody together if it can be put together technically from the point of view. But they get a chance to talk to physical therapy, respiratory therapy. They are appropriately marked. We hydrate them. They talk to me more if they have more questions, even though we already spoke at the office. So all that is very important. And by doing this, we really don't see renal failure anymore. The last time I saw a patient with renal failure with HIPEC, I think was probably about 18 years ago. And that was all related to I think this had a lot to do. And when the insurance company, we're not going to pay for the day, said, then I won't do the patient. Patient will fight with you, and 24 hours later, they are approved. So I really don't get denials anymore because this is for patient care. And actually, the outcome of the patient is going to be so much better that then really it's going to pay by itself pretty much. Surgery starts by 7:45 a.m. During surgery, the OR nurse will be contacting the family member, letting know what's going on. Surgery, varies from 8 to 12 hours. When the surgery lasts 6 hours, it's minimal disease. When you have a lot of disease and your surgery lasts 4 or 5 hours, the job probably wasn't done. And like, oh, that guy is very good. We transfer the patient to the unit. They stay there about a week, and then, of course, I go on and speak to the family and tell them what it is. And usually, the stay in the unit is overnight. Most people, actually, they get one that night. They go intubated to the room. During the night, they get the tube. Breathing for them is removed, and by the next afternoon, they are back to the floor. We get them out of bed the same day. They say, "Doctor, but I just got a big operation." Yeah, get out of bed. So, and we have our physical therapy is very good. They call her the general, because they make sure, because that's very important. Actually, early ambulation relates to complications, and we are, our average is 12 day stay in the hospital. It really takes about 7 days for the bowel to even move. So we give them parenteral nutrition in order to do that. Me and then my team will do patient with rounds every day. If I'm not in town, my partner, which also do HIPEC, will be seeing every patient every day, including weekends. If the patient are out of town, we encourage them to stay in town for a week. Why? This is a big operation. Even though it has a potential to get you in a very good condition, it is a big operation. I tell the patients, I'm going to run 2 trucks over you. Some patients told me, Dr. Sardi, you also back them up about twice. And yes, I mean, and it really, a patient is very tired, even though they feel okay. The food doesn't taste good for a month or 2, sometimes longer. It's difficult to eat, hydration. So, so it really takes sometimes 2 or 3 months just to feel back to, wow, I'm back to normal. And some of you who had the operation probably can attest to that. Some people actually do extremely well, and they, 2 weeks later, they are walking in 2 miles with us in the walk, which is interesting. And we send everybody actually home. We protect people for blood clots during the hospitalization and go home for 21 days with Lovenox. Since we have done that, we have not seen actually a single pulmonary embolism, and that goes over 10 years now, which has been very good because it used to be a major problem and morbidity for the patients. When you leave, you get a package with everything that was done, pathology, recommendations, and medical oncologists will give recommendations that has a lot of experience with these tumors. We send the record to the physician, and we continue to see a patient every 6 months. We get a baseline at 1 month, and then every 6 months. CAT scans, more often than that, has really no value. It's a big cost, more radiation exposure, and very little benefit. This operation, you can do it well, and a lot of people can do it very well, but really our success is not measured on whether you survive the surgery. The success is measured whether 10 years from now you are up doing well and enjoying your life. Now we are in the process of, actually I have to leave earlier today because tonight we have a meeting about integrated program. How do we get people quality of life to standards? We have people now alive 7 years, but they're having a lot of diarrhea. And now they say to me, Dr. Sardi, I'm cured. Can you fix this diarrhea? I have more diarrhea, and I think it's a multiple reasons why people can have that. So we're trying to create systems of how we can improve the quality of life for the side effects that sometimes we do. But while it's a big surgery, it's not a gruesome surgery, which you read in the New York Times a few years ago. It's a big operation, and the complications are similar to what we see with major surgery. In here, it's big operation, but really it's very good results. And I think that's one, in the world, the complication rate, 0%, I don't believe it, because for us, a urinary tract infection or anemia is a complication, even though, we see that with some frequency. We had 1 mortality in 1998, a patient with ovarian cancer out of, I'm approaching my 400 procedure now, 450 procedures. And we had 1 mortality in 1998 from a heart attack when she was going home. From Appendiceal, there was no one has died from this surgery. We do get complications like everybody else, but usually we're on top of the patient, we can correct those problems now. So what are the major barriers then for you to get the appropriate therapy? I mean, why are we doing these courses, and why doctors don't believe in this? I don't know why doctors don't believe in this, because as Dr. Lambert showed today, this year alone, our group alone has published like 6 papers this year alone. And all over the world, I think, when I talk to the insurance companies, they say, oh, but we are giving this patient chemotherapy. And I tell them, give me 1 paper that shows 1 patient alive, free of cancer at 5 years, free of cancer anywhere from the world. Does not exist. And that is what is called the standard of care chemotherapy. There is no data that chemotherapy in appendiceal cancer, many of these patients actually do not need chemotherapy. These low-grade mucinous tumors don't benefit from it. We give it from the other, but actually the results are mixed, and that is important to remember. So as soon as I told, but I can give you 2,000 publications about the benefit of HIPEC. Say, wow, but our expert. Say, who is your expert? And the expert is a medical oncologist that sees one appendiceal cancer every 10 years. So you have to be careful. So now Larry Todd, which we'll talk to you later, actually have been very helpful in helping patients to get through. So we get people, lead referrals. It's still today, in 2013, 20 years ago when I started doing this, not 30, 20, but we used to find we only about 6 people in the world doing this. Now we are a few hundred, I think. But there's a very negative outlook from all the physicians. Even most important in the major institutions. I mean, it's a small place. People say, well, doctor, but I went to this big place and this other big place, and they tell me this doesn't work. Why should I believe you? You are at mercy. Here's the data. So now, fortunately, which I think Memorial is beginning to do something for ovarian, and so that all those things are going to happen. But why, as a physician, I don't understand it, because there are few cancers that has as good results as this therapy is. Patients get to us very debilitated sometimes, and they come to us sometimes like concentration camp victims. So it's sad, And again, refusal of insurance, but we have become very aggressive with insurance. And patients are suing, and they should, because the results. In fact, there is a story, a patient that is a Medicare patient, came to me after two years of chemotherapy for a low-grade mucinous tumor, which doesn't respond to chemotherapy. And we did the operation, and she brought me 3 years later the picture of the children, great-grandchildren. For me, it's a very joyful to see that. And she brought me the Medicare bill for chemotherapy for the 2 years. She actually missed the last 5 months. She said, didn't have everything. Guess how much it was? $1.4 million in chemotherapy. So just to give you an idea of how all this relates about cost. Now they say, oh, this treatment is very costly. In our institution, the average cost is about $70,000 to $80,000 everything. Okay, with little complications. So when people get complications, get more. A treatment of chemotherapy that for folks with Avastin, depending on where you are in the country, one treatment that is given every 3 weeks may cost between $30,000 and $40,000. So just to give you the idea, now the new drugs are even more expensive. So we have to be careful. No, I'm not saying that chemotherapy should not be given on anybody. Yes, but we have to manage that appropriately. Techniques. There's really no standard selection criteria, open or closed. There is really no difference in survival. I look at, I started with the open, moved to the closed. The closed technique appears to be doing better, not statistically significant, but really was different time on my career. So you cannot do that, but really what makes a difference is not the chemotherapy, is the actual surgery. And that has to be determined. So there's a lot of questions that need to be addressed that hopefully we'll get some answers about that. My experience, I started this in 1994, dedicated to patient care, and actually my goal and my focus always have been quality of life. Because we as surgeons, sometimes it's easier to remove the whole colon and give a colostomy than to spend another 3 hours and taking out all the tumor while saving as much colon, so you can put it together without giving a colostomy, for example. And that obviously impacts in quality of life. About a month ago, I had a 32-year-old that never been pregnant, wanted to be pregnant, so we actually clean everything and flash the tubes, and hopefully she can get pregnant. We'll see what happens. But Dr. Lambert has a person here that actually, this one actually has delivered a baby, so it's very interesting to see that as well. And again, we apply for multiple tumors. This is after July, my experience. The majority are appendix. So I'm going to give you some statistics because where you can see what's happening and briefly to what we have learned through all these years in our practice. So DPAM and PMCA, this is the low grade, this is the higher grade. Again, remember, this higher grade is a wide spectrum of disease. But we know that if you have a low grade, the survival at 10 years is very good. Now, I can already talk about 10 years because I've been doing long enough. But look at that, if you have a low grade, 83 here, you're talking about high grade tumors, you have about 40% 10 years survival now. We have learned, contrary to other institutions, that if your nodes are positive, your survival is worse. Now, we have to be very careful as patients. We start focusing about percentage. Okay? The percentage is that we have people here who are doing very well and have people here who are doing very bad. So really, it's like a lottery. It depends on where you fall, and no one can tell you that. Not yet, anyway. So it's important that you take and don't get hung in the numbers. Now, if we do a complete stature reduction, we will increase this by 10 points. So that's why we are so aggressive. I take all the lymph nodes and try to clean everything, because we are improving, these patients by doing that. This is the largest review. The first one was what we published in 2011. This is as of last week. Really, it's almost identical with more patients now. So really, this is a true, now our pathologists are looking into that because it's important to consider. The other thing that you hear, if you have a high-grade tumor, and this is all high-grade patients, if you have a high-grade tumor and you have a lot of tumor, which is described as PCI, peritoneal cancer index, you shouldn't do the operation. Some groups will not do the operation if you are here. Look at the results, 45% 5-year survival. If we do a good operation, remove all the tumor, even though you have a high-grade tumor, and we can take it all out, look at how people do. There is no treatment in cancer that gives you that type of data. So that is very good. So you have to now, it requires more work, more treatment, more time in the operating room, but it's very significant benefit. Age. I deal a lot of people older. Some groups will not do people older than 65. But actually, look at it. If you are old, and I'm going to be 60 soon, so I'm getting closer to this age that I want to be treated. But really, age alone doesn't. So we treat people in the 70s and 80s even. It has to depend on how they're doing, and it's going to be a little tougher. They may be in the operating room longer period of time, but again, this can be done with no mortality. We had no mortality in this group, okay, and doing very well. But they do have more complications because they have more associated conditions. What about repeated HIPEC? Say, I recurred and I'm going to die. I said, no, it's not true. We have people up to 3 times, and Dr. Lambert mentioned that. 26 patients, actually, we can add another 10 patients now, but either from recurrence from our institution or for other institutions, we use melphalan. The paper has been approved for publication in the European Journal of Surgical Oncology. Melphalan is the drug that we use for isolated chemotherapy infusions of the limbs for very resistant tumors, such as melanoma and sarcoma. This is actually the first long-term publication with this drug. Dr. Sugar-Becker published something about the side effects. But really, this is a drug that is very good for resistant tumors. We use it for these tumors or for ovarian cancers that already failed all the therapies. The results are actually pretty good, and we have many people alive. You can see, the length of stay, the complications, or the mortality is not different with the first, second, and third. Actually, usually the second and third are shorter and easier operations, depending on who did the first operation, of course. And you can see even from the first HIPEC, the survival is very good. This is not from diagnosis, from the first HIPEC, so already taking away all those years that the patient had lived. So this is from our therapy, not adding years before the patient got to us. Or repeated HIPECs from the second time, still very significant survival. So really this is good, so it should not be. Now, what is new, and Dr. Lambert already said a lot about this. She actually explained it better than I'm going to, but thanks to a husband of a patient of mine, it's a sad story because he called me ahead of time and asked me about these things. Listen, you need to go to a center to do this operation. She went to a major institution and did not get the HIPEC. 6 months later, she came to me with advanced disease in the chest and everything, and she died. And he made a quest to actually find the cure for this disease. So he found me, and he even wrote a book about that, and found other people in other places, Uniform Science University. And we identified that this H. pylori and other bacteria is present in the mucus on these tumors. Now, you may know that H. pylori is associated in some cases with gastric cancer, some gastric lymphoma. If you treat the bacteria, in mast cell lymphoma, the tumor will go away sometimes. So we found actually there was a gene, a virulent gene, a bad gene in this bacteria that was present in these tumors outside of the appendix. It's not, and we are not seeing infection, we are not seeing pus. So what does this mean? So we treated a group of patients with antibiotics, and we found that we can decrease the incidence of bacteria in patients by giving preoperative antibiotics. This is really a well-accepted therapy for, that we use it for treating this bacteria in the stomach. And we found this. And further research actually identified that it may be also associated with the ability of these tumors to metastasize. And it's some of the things that we are looking actually from the histopathology point of view that our pathologists are looking at, is that the CAG, the beta-catenin, is a membrane protein that makes the cells join together. When that is lost, and many cancers do that, especially people with pseudomyxoma, these cells tend to metastasize, go all the places. The people who got the bacteria, and it moves from the membrane, from the outside of the membrane, it goes into the cell, inside the cell, so it doesn't have the ability to do that to the cells. We found that people who got the antibiotics, that was better, it kept the protein outside, and the people who didn't get the antibiotics had higher concentration of this protein inside the cell, and which is bad for metastasis. And this has been shown in other tumors, in colon cancer and other tumors, to maybe a significant reason why people metastasize. We're also looking at a variety of genes that Dr. Lambert are doing here. And we look at this VEGFR, is vascular endothelial growth factor receptors. Now we are going this medicine that goes to the cell. Instead of looking at the patient only, we look at the cell and see what can we do to the cell to try to block tumor growth. And interestingly, this is not statistically significant, but this is probably not enough patients. But when you look at the numbers, this is very, very interesting. Actually, it will be published in Journal of Surgical Oncology. But it's kind of interesting to see that the difference on this. So we are, of course, now doing one with more patients. Other issues which are important for management, laparoscopy. We use laparoscopy depending on the patient to try to determine what patients are candidates for the big operation. Usually, these ports, it's called ports, they are usually placed in different sides of the abdomen because it's easier depending on that location. If you have peritoneal carcinomatosis, do not let your surgeon put them outside of the midline. Why? Because tumor tends to grow through these port sites. It becomes difficult to remove when they recur, and it's a real problem. More importantly, we look at the significance of this, and people who have port site recurrences actually do worse. Now, is this something related to the port site placement? I doubt it, although we have had some major wall resections because of that, or is because it really portrays that you have a bad disease. This is actually brand new. The other thing that we found about, we're trying to determine, we have found in the past that if a patient took more than 6 months to get to us for therapy, or to a center, of course, that does these operations, the survival is worse. And you say, okay, let's look at about the patients that had limited surgery. When I say people who had a hernia repair and they found mucin there, or they had appendectomy only, or had a percutaneous biopsy of a big tumor, if you come to us and you have a low amount of tumor, less than 20, everybody's alive, if you came with limited surgery. If you have less than PCI, but someone decided to remove your ovaries, your uterus, and something else, then your survival markedly decreased, and it's statistically significant. This is not published yet. We just found this last week. So there's a compelling evidence to show the importance of early referral to a center to do the appropriate surgery, one operation and a 2 or 3. So that is actually now, again, I see some of you already, oh man, what is going to happen to me? But again, these are numbers, percentage. This applies to a large number of people. It doesn't personally apply to you because, again, the people here are doing very well. Many, some were lost. But the problem is when you have a lot of disease and surgery happens, tumor grows into these areas. There are growth factors that make the tumor grow in these areas, which make surgery, follow-up surgery, more difficult. And actually, even all the groups, when we include people even with advanced disease that had major surgery, when you have come to us with a lot of tumor, more than 20, still do better than the people who have bigger operations before they got to the high peg. So really, the idea is how do we coordinate the efforts to really improve the quality of life. We had a lot of people living a long time, doing well, but there are issues on quality of life that now we have to put attention, and that's where we are right now. Nancy, 75-year-old, 6 months after a high peg, won a 2-mile gold medal in her age group in swimming. I cannot do that. Now she does a golf event. I mean, she does a swimming event every year. She invited me this year. Said, "No, I'll do it next year." So it's nice to see this. It's nice to see people having normal life, running their business. Unfortunately, in the internet, all you hear is about the bad stories. And I tell we probably should all get together and do this website, and everybody who's doing, had the operation, good or bad, should send just once a year, hey, this is my picture, this is my family, thank you. For me, it has been great to go to weddings, graduations, because say, wow, I wasn't supposed to be here, now I'm here, I want you to be present. So for me, that is really very, very, very grateful. This we do every year. We are a small institution, so we don't get money from grants. We are not a university, so they don't look at us as a good guys to do research, although we do actually a very good job, and we are very prolific on that event. But our patients get together, and this year we raised $157,000 in a walk in the Inner Harbor, thanks to the contribution of patients. And really, it was great to see everybody walking and having their families and raising children and so on. So in summary, early treatment leads to better outcome. It's true on any cancer, more so in this one. It is applicable to a variety of malignancies. This is not single to appendiceal tumors. Because you have an aggressive tumor, a signet ring tumor. I have signet ring cell tumor with positive lymph nodes that are alive at 10 years now. So that alone doesn't mean you're going to die. You just need the right operation. Okay? Now, these people do worse, but it's not zero. And if you don't do anything and you only get chemotherapy, your 5-year survival is going to be 0. So, that's what I want you to remember. So, having a lot of tumor is not a contraindication. You just need the right group to do your operation. Older patients also benefit. Just because you are 70 years old doesn't mean you need to die. When I was in training, a long time ago, if you actually were 70 years old, it was time for you to go. Now, I'm not sure. So close follow-up is important for the recurrence. I follow all my patients every 6 months. I have people from out of the country, so they send me the CAT scans, so I review them, because we have people that were lost for follow-up. They go to their groups, and they see the recurrence, and that's very negative attitude. Oh, you already had the HPEG recur. So by the time they come to us 2 or 3 years later, they have massive disease, and we cannot help them. We have shown that if we follow people closely and they reoccur, we can go back and do another HPEG and keep people alive, and many of them are cured, actually. Okay? And again, these are experience centers. It is known now, and the Italians published that you need about 150 cases to be prolific now. So that's important. Again, I'm glad to see that every time that I go to this meeting, we see more and more people, and working together is what is going to make the difference. Because I think we are actually helping all of us to have a better future and better families and enjoy life, and that's what it's all about. So thank you very much.
So thank you very much, Dr. Sardi. We're running a little bit behind on the agenda, and Dr. Sardi actually has to leave early, so he won't be here for the question and answers at the end. So we'll take a break now, and if you have some questions for Dr. Sardi, maybe you can catch him before he has to leave. All right, thank you. No, we were 15 minutes behind, and your timing is perfect. Thank you. And your